Thank you so much for coming back and joining us today. So we are here to discuss adenomyosis, which does not get nearly enough attention.
So happy to be here, and I totally agree. Adenomyosis is it's probably harder actually to treat than endometriosis, I think, because the options are more limited.
Yeah, and just to go back to a brief explanation of what exactly is adeno.
So adenomyosis, a lot of people call it like endometriosis of the uterus because it's endometrial glands and stroma that are now hanging out within the uterus wall, the myometrium. And the problem with adenomyosis is that it's within that wall, and the only true way to is hysterectomy.
Right.
But that being said, it's because it's invading the lining, so it's not like a fibroid, which for some people it's outside of the uterus where you can just take it off. It's invading that lining, which makes it too hard to like take off, because you either you take the uterus out or you keep it.
Right. Because otherwise it would be too invasive. And I've heard that there's other techniques that they do to try to take, like there's different kinds of adeno lesions, if I'm saying that correctly, where there's like a focal point or a diffuse adenomyosis.
So for some patients, if you've heard of uterine artery embolizations, that is basically trying to cut off the blood supply to the adenomyosis or the uterus. And that can sometimes give pain relief. In my opinion, of what I've seen, it seems to be like, I don't want to say a percentage, but it doesn't always work. And so limiting the blood supply to it is like hopeful, and trying to basically spare you some time before having to have a hysterectomy. And then it's definitely worth a shot. I mean, any patient that's considering taking out a uterus, I always tell them, no guarantee that that's definitely going to give relief. And I guess it also matters on how much of that adeno is diffuse. So if it's in one area, it's a possibility that cutting off the blood supply will help. But if it's all over, it's probably not going to be as effective.
And with that kind of procedure, does that weaken the uterus so that if someone wanted to carry a child, would there be a higher risk of miscarriage?
I mean, the hopes of doing it is so that they can keep their uterus, so that they can carry a child if they need to. This procedure is also used in patients who have pelvic congestion syndrome.
Okay.
And there are many patients who have had pelvic congestion syndrome and carry children, and same with adenomyosis, carry children. I think it just matters of how diffuse the adenomyosis is, because the blood supply is the good thing about our bodies are that we have multiple different ways, different places for blood supply. We have everything we have on the right of our body, we have on the left of our body. So in that sense, we're lucky, because, and there's not just one artery that goes to the uterus. There's so many smaller, independent little branches. So we're not dependent on just one, like cutting off the supply to one artery. That being said, a lot of patients will say, should I do this uterine artery embolization before I freeze my eggs? Should I freeze my eggs? Will it affect it? And, a lot of times I'll have that an interventional radiologist, because they're the ones who do the procedure. So it's not actually a gynecologist that does the uterine artery embolization. I mean, I think in medicine, there's a little bit of overlap in these fields, but there are interventional radiologists who do the procedures because they are kind of trained in looking at blood supply. And there's different imaging for uterine artery embolizations versus like an MRI or an ultrasound. You can't just see the blood vessels on an ultrasound. I mean, you can see them, but it's not like good enough. And, you know, they might require contrast. So these specialists who do it, they'll say, well, no, you know, I don't think you should freeze your eggs before you, or you should do a uterine artery embolization before. But some will say, freeze your eggs. Like the MFM doctors are going to say, yes, freeze your eggs before, because you don't want to risk decreasing the blood supply to the ovaries. So it's mixed, and it also depends on so many other things in that factor too.
Right.
Where your egg supply at, what is your uterine lining like? Would you be able to, do you have any blockage in your tubes, etc.?
Yeah. And in terms of the adenomyosis symptoms, what are some symptoms that people can look out for?
So there are a lot of the same symptoms as endometriosis, which can be very confusing.
Yeah.
Because, you know, a lot of patients, they come in and they say, I have painful intercourse, I have really long periods, or I have really short periods, or I have really heavy bleeding. And then that uterine contraction that's happening every month with the menstrual cycle. So that's more classic adeno. And it's not to say you don't have that with endo, but because endo and adeno are so closely seen, just like interstitial cystitis and endometriosis are so often seen together, the same thing. A lot of patients who have endo don't know they have adeno, and it's not really even discussed with them because they may be in their 20s, and GYN doctors may not be discussing the possibility of adeno. So, you know, before a patient goes for surgery, I usually tell them, you know, make sure you speak to the endosurgeon about the possibility of you having adeno, because I don't want you to have this endometriosis surgery, feel like, oh, I'm going to feel like $1 million when I come out. And then they say, oh, well, you have adeno, and that's probably why you still feel bad after the surgery. So you should be aware. And if having children is something that's very important, or, you know, it really depends on the age. How long have you been having the symptoms? Are you in your 50s? Are you in your 20s? Having that conversation of, if I have adeno, if I have endo surgery now, at this point in my life, that I want to look, have the GYN surgeon look for adeno or not.
Yeah.
And adeno can sometimes come up on MRI. So that actually is a little bit easier to diagnose. So despite the fact that there's an overlap in the symptoms between adeno and endo, it's actually a little bit easier to diagnose.
Okay. But is it always picked up, or can it not be seen all the time?
It's not always picked up, but it's definitely more picked up than endo, which is almost, I mean, never picked up.
Yeah, that's true. Yeah, for sure. What are some treatments that could help other than anything that's a surgical intervention?
Okay, so non-surgical, if there is, you know, contractions of the uterus and you're feeling it with your menstrual cycles, well, sometimes people, and they're heavily bleeding, like a lot, one more surgical option is just cleaning out the inside of the uterine lining so that it decreases the amount of bleeding. Okay, so non-surgical, there is also the option of suppositories to decrease the contractions with muscle relaxant. So the suppositories with either a muscle relaxant or even like an anti-inflammatory. So it's kind of like putting a leave inside of your vagina. And the thing is you have to make sure it doesn't hurt or burn, but it can help with people who are having that menstrual, like uterine contraction. Oral muscle relaxants can sometimes help. Typically, anti-inflammatories don't really do much,
Okay.
but you know, if a person wants to try, I'll often give patients creams that they can put on their uterus, like all over their lower abdomen, and you know, try to decrease the contraction. So sometimes the creams can have muscle relaxants in it, as well as lidocaine or some sort of numbing or a cream as well, or a pain reliever.
And with adeno, I've heard when I've spoken to some women that say that they have it, they complain of having joint pain or swelling as well, like water retention, and also just feeling overall like this fatigue, this muscle fatigue, joint pain. Is that also related to adeno as well?
I mean, adeno, just like endo, has a lot of systemic side effects. So not side effects, systemic symptoms, because it is like a total body, disease. So you can present with fatigue and nausea and vomiting and pain, and some of the more classics are just focused directly on the uterus, but just like endo, and also is that person having adeno plus endo? We don't know.
Yeah, and God knows what else. Like the way there's comorbidities. Is it RA? Is there something else presenting? Because so many of these things become
Ehlers-Danlos, So there's so many, ankylosing spondylitis, like any SI joint dysfunctions. So immunologically, there's so many comorbidities, and like it can be super complicated.
Yeah. And it's hard, like you said, to differentiate. Is it endo? Is it adeno? Is it also, both of these plus something else that no one's even looking at because they're so quickly putting it under one umbrella? And just to kind of sum up everything, even though there's just a lot there, what would you tell someone who's dealing with symptoms of adeno? Is there anything that you recommend that they can try to talk to if they're going to their gynecologist, that they can try to say, like, I think I have these symptoms, what can I do for them? How would you recommend they advocate for themselves?
I mean, I think that if a patient has concerns of having adeno outside of having endometriosis, I think speaking to them the same way they would someone who has endometriosis, discussing that there is a possibility, having them do regular ultrasound imaging, MRIs, to see if there is a possibility of having adeno. It's really often missed, and unfortunately, just because of healthcare in general, unless you go to a specialist, not everyone understands it. But adeno typically is seen more because if the uterus looks more enlarged, they can say that, okay, well, it looks bigger than it should be. That means there's probably something within the lining, when it could possibly be adenomyosis. And then, just kind of deciding, knowing that there are few options, maybe having an interventional radiologist consult, or, have, if that's something that is accessible in the town that you're living in. Because I think they're also a little bit more in tune with don't do thyroid procedures. You might need like a more subspecialized person who is willing to look into that, but definitely start off with an MRI pelvis, with or without contrast, depending on the doctor, if the patient has any interactions with it, and really telling the doctor that this is not normal. It's not just a painful period. It's not, you're not supposed to feel like you're dying every month.
Right. Exactly. No, well, thank you for talking about this with us. And I would love to have you back on to talk about the comorbidities that go and align with things like endometriosis and adenomyosis. But thank you for all that you do and for carving out a little bit so we can educate on this.
No, I totally appreciate it. It's super under discussed, and so many of my patients have no idea. I've never heard it, even after seeing endometriosis surgeons, and I have to explain to them that there is this thing, and it's also overwhelming because they barely know what endometriosis is, and now they're like, wait, there's one more thing that could be causing my pain. And even after the surgery, I might, because I hate when patients go into a surgery thinking there's this expectation you're going to come out 100% better. So unfortunately, you know, I do talk about it a lot within my patients, because they need to know what their options are, and I don't want them getting this false impression that endometriosis surgery is going to cure them and make everything all better.
Right.
Unfortunately.
Yeah. It's there's no easy fix. There's some help, but there's no real easy fix at this point. Let's hope for one in the near future. Thank you.
I think the only thing we can do is like educate, right? So as long as you're educated on it, you're not, and you know the options, because you know the other thing is, in the rest, some parts of this country, they say, oh, adenomyosis, hysterectomy. They don't tell them that there's these options of uterine artery embolizations, endometrial ablations, or maybe freeze your eggs before. So now everyone's kind of feels like they're forced into a back alley and they have to take their uterus out. So not always the case.
Yeah. So the education component and arming yourself with the knowledge so you can be able to make more present choices without feeling, like you said, backed into a corner on something. Well, thank you.
No problem.
We'll see you
Have
again.
a great day.
You too. Thank you.
Okay.
Thanks, Doctor.